Welcome back to Coffee Convos on Trauma Coding, where we sip with intention and code with confidence. Name That Fracture is our first series of this channel. I hope you can all tune in to all 12 episodes in May. I'm Amanda Truelove, and for those who may be taking your first Coffee Convos on Trauma Coding Break, in this series, we are breaking down named fractures one pattern at a time so that you can identify the injury, understand the anatomy, and make better coding choices with confidence. So pour your coffee and let's get into it. Today, in episode 3, we are diving into one of the most important pattern recognition episodes in the entire series. Now, AI was used in the generation of the illustrations for this series. The illustrations are to help teach trauma coding concepts and fracture pattern recognition. The education visuals are not intended to be exact injuries, procedures, interventions, or patient-specific anatomy. Always follow provider documentation, imaging, operative reports, official guidelines, and your facility data source hierarchy and policies when performing your professional duties. Ethical coding is our expectation from this education. Today's episode is forearm combination codes. Monteggia, Galeazzi, Essex-Lopresti, Hume, and Nightstick. Now, if episode 1 laid the foundation, and episode 2 taught us that named shoulder injuries are not interchangeable, episode 3 is where coders begin to really sharpen their eye for combination pattern injuries. Because forearm eponyms teach us something critical. Sometimes the first broken bone you see is only part of the story. Sometimes the fracture is isolated. Sometimes the fracture comes with a dislocation. And sometimes the fracture is only one piece of a much larger instability pattern. That is why the coding lens for today's episode is really simple. Do not stop at the first broken bone. For your forearm injuries, we have to identify the entire injury complex. So throughout this episode, every time you hear an eponym, you should ask, what is actually broken? What is actually dislocated? What joint is unstable? And is this an isolated fracture, a fracture dislocation, or is this a fracture with associated instability that changes the entire coding conversation? Well, let's get into it. Let's start with Monteggia. So the Monteggia fracture is classically that ulna fracture with radial head dislocation. That is the defining pattern. It is not just an ulna fracture. It is not just an elbow injury. It is a combined injury pattern that involves both the forearm fracture and the elbow joint relationship. So for our pattern check, what are we looking at? We're asking what is actually broken or dislocated. Well, that answer is the ulna is fractured and the radial head is dislocated. And that matters. Because if we only capture the ulna fracture, we miss the part of the injury that makes it a Monteggia. This is one of the clearest examples from orthopedic trauma of why coders must ethically and completely evaluate the full pattern and not just the fracture line. For our coding choice, we're asking, is this an isolated or a combination code? Or is this a fracture plus a separate associated injury? So in working through teaching the Monteggia's fracture, this should be approached as a combination pattern injury. Why is that, do you ask? Because the injury is defined by both components, both the ulna fracture and the radial head dislocation. So your coding mindset here is do not code the ulna fracture alone and just move on. This is a fracture dislocation pattern. So if we're looking at our documentation and thinking about our pearl of wisdom here, what must the provider say for accurate coding? Well, we need from the provider clear documentation on laterality, that ulna fracture location, whether or not there is displacement, and whether there is an open or a closed fracture pattern type, as well as that radial head dislocation or subluxation description, along with, last but not least, any associated nerve injury if present. We learned about that in our episode 2, eponyms, correct? You remember that? So the eponym is helpful, but the anatomical components still need to be clear. We don't want to spill the chart, right? So where do coders commonly miss or mistake when coding this? The common miss is exactly what this episode is warning against. Capturing only the ulna fracture and missing that radial head dislocation. Another common mistake or miss is allowing the injury to stay documented as just some sort of generic forearm fracture, when there is elbow alignment that's actually part of the pattern. Okay, so if we have that misalignment of that elbow, we need to capture that. So our take-home SIP is that a Monteggia's fracture is not just an ulna fracture, right? It is actually going to be that ulnar fracture plus that radial head dislocation. And the full pattern is going to drive our coding logic. That's important to understand. And understanding the relationship of both of those bones in relation to that elbow joint is critical for our code assignment and how we interpret and can kind of visualize that documentation for that injury. So when we are trying to assign this, we do have a singular code or an eponym within ICD-10 to capture that Monteggia's fracture, which is that fracture of your upper ulna shaft with a dislocation of the radial head. We also have options for the laterality, and in those less than desirable documentation situations, we have that unspecified ulna as an option as well. Now, you can see here that we have, as part of our conventions, for that fracture of the upper shaft of the ulna with dislocation of the radial head. It's part of the conventions in the inclusionary terms description for what a Monteggia's fracture actually is. While it is coded to the ulna, this Monteggia's, because we are assigning it to the eponym code description, right? Then we know that that includes that radial head dislocation. And that is where it is part of our professional responsibility to understand the fracture patterns and the injuries patterns for these eponyms so that we assign them appropriately and do not over or under code. When you have the eponym, and that includes, like we see here, both the ulna and the dislocation of the radial head, you would have one single combination code. That one code, according to the conventions, would include all of the injuries, and therefore you would not assign multiple codes to capture both injuries documented. All right, let's move into our second SIP for this session, which is Galeazzi. And that eponym fracture is classically a radius fracture with distal radioulnar joint disruption. Boy, that's a mouthful. Now, here we have another injury that is going to teach coders not to stop with the fracture alone. Instead, we want to do that quick pattern check and ask what is actually broken or dislocated. So the radius is fractured. And then the distal radioulnar joint, or DRUJ, may be an acronym you see documented, so take note. That joint is disrupted, unstable, or dislocated. So this is not simply just a distal radius fracture. It is a fracture, but there is also joint relationship injury at that wrist level that is involved. And that is important because as we start to look at that fracture pattern, we understand it is going to impact our code choice. When we start asking, is this an isolated, a combination code, or a fracture plus a separate associated injury, we can quickly determine through the teaching today, right, that Galeazzi is another combination pattern injury. The radius fracture and the distal radioulnar joint disruption belong together as a single injury pattern. It is one complete injury pattern. And when that happens, you want to make sure that as a coding professional for trauma, you are not only capturing the radius fracture and then missing that distal forearm joint disruption. So the injury, if you do that, is going to be underrepresented. Well, how do we know what to assign? When should we assign just that radius fracture versus this Galeazzi? Well, our documentation pearl tells us that our provider will provide the details for accurate coding and clearly document things like laterality, your radius fracture location, that displacement or non-displacement of the actual fracture, whether it's an open or closed injury pattern, and whether you have that distal radioulnar joint disruption or subluxation, maybe also any instability or any associated ulnar styloid or wrist findings. So you could have this Galeazzi fracture, and because of the nature of where it's at anatomically, you should look and see, do you have any associated additional common injuries, such as that ulnar styloid or wrist findings? And if they're present, you want to make sure that you assign those. So with that understood, we know the distal radioulnar joint language. It's essential. It's essential in being sure we don't spill this chart, right? And make mistakes with our coding. So our common coding miss is focusing only on the radius fracture and not reviewing the wrist alignment. Not checking those operative notes for the distal radioulnar joint instability. Another is people hear or read Galeazzi and just assume the eponym alone is enough. And they don't even bother confirming how the joint disruption is documented. You know, we need to make sure that it's associated with the fracture and that they're not too separate. So we all make mistakes. So our take-home SIP here is that a Galeazzi fracture is a radius fracture with disruption of the radioulnar joint. So that wrist joint relationship really matters just as much as the broken bone. Check that documentation and make sure that you don't have a fracture to the radius on the left side, and then the joint disruption is on the right side or in the right arm. They have to be together in that same location. That is when we are appropriately assigning this single eponym code on the S52.37 subdivision code category. And of course, we have options for laterality of left or right. And then, just like before with Monteggia's, we have the ability for those less than desirable documentation situations, that unspecified radius. Work to improve that if you're seeing that a lot at your trauma center. Now, we do have this index search, and you can see the tabular list provides the inclusionary term for that convention about radius with radioulnar joint dislocation. So therefore, you do not need to assign two codes. This Galeazzi fracture for the tabular list provides us a combination code that includes both of those injuries. However, if we have fractures at the wrist and or hand level or those associated ulnar styloid type injuries, we want to be sure to assign those additional codes following our excludes 2 and then our multiple code convention for ICD-10. Here we have a great little coding pearl. We have that Monteggia's versus the Galeazzi fracture from orthopedic surgery, and I'll put the link to this YouTube video in our chat and pin it at the top for the comments, but you can see the difference quickly. So while you have a fracture of the ulna and the radius and that joint involvement, and you do have the radius involved in both fracture patterns, what you should pay attention to is that your Monteggia's is your fracture of that proximal end, right? That radial head. And then your Galeazzi is your distal fracture. So it's the distal third of the radius. And that is the key coding pearl that I would like to provide just to kind of help you keep both of those separate and not get those confused. All right, moving into our next fracture eponym, which is Essex-Lopresti. This injury is classically a radial head fracture with interosseous membrane injury and distal radioulnar joint instability. Boy, this is one of the best examples of a named injury that extends beyond one bone and one joint. When we look at this pattern and try to check what's going on, and we're asking what is actually broken or dislocated, well, we know that the radial head is fractured, but that is not the whole pattern, because we have that interosseous membrane is being injured, and we also have the distal radioulnar joint being unstable or disrupted. So this really is a pattern where you have a longitudinal forearm instability pattern. And the key phrase for coders to understand here is that because if you only see that radial head fracture, you may miss the bigger picture in that injury complex. And that's important when we start looking at our code assignment, because we're asking, is this isolated? Is it a combination code? Or is this some sort of fracture pattern? Or is there some other separate associated injury? Now, your Essex-Lopresti is understood best as a fracture plus associated instability pattern. Now, what does that mean? That sounded like a mouthful. Well, it is not an isolated radial head fracture, that is for sure. And unlike Monteggia's or Galeazzi, the instability extends along that forearm and through the interosseous membrane and into that distal radioulnar joint. So it's going to extend down into that region. Okay. Well, then it's our job as coders, professionals, and to do all we can diligently to recognize these fractures and determine that the fracture is not only one part, or rather, it is only one part of the documented injury, and it is not the full injury. So your fracture is only one part of the full injury. Well, then we need to talk about some documentation pearls, right? What must our providers say for accurate coding? Hopefully, they are providing you with laterality, whether there's radial head fracture details. Hopefully, they are helping you with information on that interosseous membrane injury when it is identified, and whether you have a distal radioulnar joint instability and subluxation or dislocation, for example, as well as any wording about longitudinal instability for that proximal migration when it's present, and whether the injury is acute and current. Now, this is one of those patterns where buried orthopedic details can make a major difference, okay, in helping us hopefully not spill the chart. Because coders, trauma coding professionals commonly miss the biggest miss, I would say, is treating your Essex-Lopresti like a simple radial head fracture. And then another would be not reviewing the wrist or forearm when the elbow injury is documented, because this pattern is bigger than just the fracture seen at that elbow. Okay, that is kind of our take home sip here, is that an Essex-Lopresti injury is not just a radial head fracture. It is a longitudinal, okay, long, just kind of pointing that out, forearm instability pattern. And in order to assign the appropriate code, we need to understand what all is injured, and that we will not. So with Monteggia and Galeazzi, we had a single combination code. There is no single code, no combination code for your Essex-Lopresti fracture or injury pattern. Therefore, we have to pay attention. It is even more critical that we pay attention to the documentation of all of those injuries and to which body parts and regions, because your radial head fracture will be assigned to that S52.12 subdivision of the code. And then when you start looking at your distal radioulnar joint dislocation and that instability, you will go into the S63.01 subdivision of the code, of course, when it's appropriately documented to do so. And then you've got that interosseous membrane injury, and that's going to usually be assigned as a separate injury in and of itself as well. So you must capture every component, not just that broken bone. So let's look quickly at that Galeazzi versus the Essex-Lopresti. So you have two patterns, right, at different levels, and you have a much bigger instability in that Essex-Lopresti than what you saw with the distal radioulnar joint disruption in the Galeazzi when you start reviewing the Essex-Lopresti. Okay, so hopefully this helps you. I would just say, that key difference that we're trying to point out here is that you have a radial shaft fracture with both. And you do have some radioulnar joint disruption, but in the Essex versus the Galeazzi, it's the radial head. So the position and the level at which the radius is fractured is different. And you have an additional or a third injury, that interosseous membrane disruption for the Essex-Lopresti. So it is a larger longitudinal instability pattern, as you can see illustrated here, than what we have with just that Galeazzi. So just try to pay attention to that and be sure that you're capturing all of those components that are injured. So we kind of break it out for you here in this little coding concept and give you that S52.12 for your radial head fracture. And then that interosseous, again, I told you it's going to be a separate, and that will be assigned, and you'll start with that tear or torn ligament, which will give you the C convention for the sprain of ligament by sight. And if you're looking at your radiocollateral, then those will be in the S53.2. And if you're looking at your ulnar collateral ligaments, then you're going to be in the S53.3 subdivisions of your codes, as you can see highlighted here on the screen. Now, your dislocations, of course, are going to be out into the S63.01 because it's that radial ulnar joint and it is the distal end. So it would not be assigned to the elbow. So it would be down in the S63.01. And of course, you're going to follow all of the conventions and guidelines provided in your tabular list where you will assign that full code from. And that wraps us up with that one. And now we're going to move into the Hume. So now we have that other fracture, the Hume, which is classically described as an ulcranon fracture with a radial head dislocation. Now, it is a much rarer forearm and elbow eponym, but it fits beautifully into today's teaching theme. As we start to look at that pattern check, asking what is actually broken or dislocated, well, it's pretty simple. The ulcranon is what is fractured, and the radial head is dislocated. So again, this is not just going to be a proximal ulna fracture. It is a combined elbow injury pattern. And that is going to impact, once again, our coding choice. When we start asking ourselves, is this isolated? Is it a combination code? Or a fracture plus some sort of separate associated injury? Now, Hume should be thought of as a combination pattern fracture dislocation. The fracture and the dislocation are both central to the eponym. This is yet another reminder that coders cannot let the fracture alone tell the whole story. Our documentation pearls for this include, asking, when we're asking and trying to determine what must the provider say for accurate coding. Well, they must clearly document that laterality. No surprise there. That's our common theme we're starting to see, right? Your ulcranon fracture, they do have to document it as an ulcranon fracture. They should be providing whether it's displaced or non-displaced, whether it's open or closed. Hopefully they're providing whether there's radial head dislocation and any associated elbow injuries when present. Because this is a less commonly recognized eponym, the component description is especially important in helping us be sure to not spill this chart, right? It's easy to make mistakes and make, common coding mistakes or miscoding some of the injuries. The biggest mistake is coders will only assign the ulcranon fracture and not recognize the radial head dislocation. Another is just confusing this with a Monteggia's type language, seeing those descriptions and trying to confuse it. Now, that's an easy thing to do when you don't read the anatomy carefully. So again, we have two different patterns, right? And the problem is we have different bones, but we have the same dislocation. So your Monteggia's involves your ulna, your Hume involves the ulcranon, and then both involve that radial head dislocation. So people will see that radial head dislocation and then they'll see something, a place on that ulna that's fractured and not identify that it's really two different locations where those fracture patterns occur, as you can see here. So that is easy to do just when you're reading and you're in a hurry. So just take time and pause, take a sip, and relax and read through it one more time when you get ready to assign those out. Now, we do have options. So our ulcranon process that displaced is going to code out to the S52.02. When you have an intra-articular extension, it would be assigned to the S52.03 subdivision of the code. And then that radial head dislocation, the S53.006. And then you have options for anterior or posterior or specified type of dislocation, not elsewhere classified. So if it's not anterior or posterior, or maybe it's anterior lateral or whatever, then that would be an option for the S53.09. But if you just have the anterior or the posterior, of course, you see those code out respectively to the S53.01 and S53.02 subdivision code categories, respectively. All right, so our Hume code choices here. So we have those, and hopefully you're able to use this and determine when you have an olecranon fracture that it is not a Monteggia's, it is actually a Hume. And because you do not have a single code, so we do not have a combination code for the Hume fracture, but that doesn't mean we can't assign it. We've provided you with all of those details on code assignment for each of those injuries individually when you have documentation to support that you actually have a Hume fracture or they diagnose it with a Hume fracture, and you should be able to then assign that out. Here we have those alphabetic index and those illustrations for the olecranon. So not the shaft, but the olecranon, and then how to assign that out. You've got that olecranon process and displaced or non-displaced, and with and without that intra-articular extension. And there you have those subdivisions of the codes that we just discussed. And then, of course, because this fracture pattern, so the Hume fracture does include that radial head dislocation, because we had that fracture plus that associated dislocation, you must assign a secondary code for these when it is truly a Hume fracture. And that brings us into our nightstick fracture. So our nightstick fracture eponyme is demonstrative of an isolated ulna shaft fracture. It is usually caused by direct impact. And this is the perfect contrast injury for today's episode, right? So when we're thinking about fracture patterns and checking what is actually broken or dislocated, in this case, the ulnar shaft is fractured, and there is no defining dislocation component in the eponyme itself. And that is exactly why Nightstick is useful in this episode. It is a great reminder for us that sometimes the injury, well, it really is just isolated, but that has to be confirmed, never assumed. It is still going to impact our coding choice, right? Because we want to know, we're asking ourselves, is this isolated? Is it a combination or a fracture plus an associated injury? We're always asking ourselves that for each eponyme. And your nightstick is typically, like I said, going to be that isolated fracture. But coders should still look carefully at the chart, right? Read those imaging and radiology reports to be sure. We want to check, it's our ethical duty to make sure that there is not a more complex elbow or wrist instability pattern hiding behind the documentation. Okay, so within our documentation, some of those pearls we're going to look for still include laterality, still include the location on the ulnar shaft. So we're starting to see that site, right, is extremely important when we're talking about shaft fractures. The site on the shaft itself is critical detail. Also looking to see if we have an open or closed wound pattern, and then whether there's displacement or if it's non-displaced, and then whether the fracture is truly isolated. So we want to trust, but we also want to verify. So if they call it a nightstick, we're going to verify that there are no associated radius, elbow, or wrist injuries. So really that word isolate is what matters most here. That is how we're going to be sure that we don't spill the chart and inaccurately or incorrectly assign the code. So the common miss is assuming that every ulnar fracture shaft is just a nightstick fracture and not confirming anything else that could possibly be involved. So that is exactly the habit this episode is trying to correct. Okay, so our take-home SIP for a nightstick fracture reminds us that sometimes the forearm injury, well, guess what? It really is isolated, but only after we confirm The rest of the injury complex is actually intact. Okay, so we do have some examples here. So that nightstick fracture pattern. So we've got that fracture of the upper ulna would be assigned to the S52.20, depending on where it's at. So if it's isolated to the upper, this would be where you go. If you have a shaft, just proximal third or distal third or even middle shaft fracture, and you also have these options. So we're looking at these, and this is actually like you would most of your fractures with an eponym. So if they are described and documented as an eponym type fracture like nightstick, it's going to be into that specified, not elsewhere classified, unless you have additional details of what that fracture pattern would be. Okay, so this is your mid shaft. And then, of course, you have your ulna lower end, which could be the S52.6 or the S52.90. Okay, so that lower end, that unspecified, we're not really sure what's going on there. And then we have that specified, not elsewhere classifiable, which is more than likely where we would be for that, as well as the S52.59, okay, which is the specified type NEC if there is any sort of physical type injury included as well, which would truly be moving it into a different fracture pattern. So, and working to wrap us up for today, your forearm eponyms are going to teach one of the most important habits in trauma coding, right? So if the name includes both a fracture and a dislocation pattern, do not stop. Do not stop after that first broken bone you see documented. You want to trace the whole injury complex. You want to identify the fracture site, identify that joint involvement, look for instability language, and decide whether the injury is isolated, a fracture dislocation, a fracture with associated instability that changes your entire coding conversation. Now, that is the real teaching point of episode 3, right? Not every forearm fracture is just a shaft fracture, and not every named injury can be coded correctly without understanding that full pattern. So, in moving forward, that final SIP would really be that your forearm eponyms teach coders to follow the entire injury complex, not just the first broken bone, but the dislocation, consider joint disruption, look for instability that defines the true pattern. Now, in our next episode, we are going to move into the wrist, where dorsal, volar, articular, and dislocation wording can completely change the conversation again. Now, I hope that ye all stay diligent in your abstraction and code assignment. I really hope that you keep working to make a difference in injury prevention, stronger trauma systems, and better patient care through quality data. I am Amanda Truelove, and trauma truly is my heart's work. I hope to see you all soon with our next fresh pour. Now, if this episode has been helpful, please like, share, subscribe, and comment to support the channel. I hope that you'll consider sharing with trauma professionals and others who can help expand the reach of this content. That will truly make a difference in our ability. It's your engagement that's going to help grow the platform, increase visibility, and build the sponsorship support needed to keep this additional resource free for the trauma community. See y'all next time.